Good morning, everyone. I'm Dana Corson, Media Officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us this morning for a webinar on the report that was just released titled Dietary Reference Intakes for Sodium and Potassium. You can now download a copy of the report and other supporting materials at www.nationalacademies.org/DRI Sodium Potassium. And you can follow the conversation about the report on social media using hashtag DRI Sodium Potassium. For those of you not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, we are private nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. For each requested study, panel members are chosen for their expertise and experience and serve pro bono to carry out the study statement of task. The reports that result from this study represent the consensus view of the committee and must undergo external peer review before they are released, as did this report. I have with me a few members of the committee to discuss the report's findings, but before I introduce them, I would like to go over a few technical reminders. After the opening remarks, we will begin to take questions through the Q&A button on the bottom of your screen. And if you have any technical issues during the event, I'm going to give you a phone number to dial. That phone number is 1-888-799-9666, and you select option 2. Now I'd like to introduce the members of the committee who are here with us today. We have Dr. Virginia Stallings, our committee chair, professor of pediatrics at the Children's Hospital of Philadelphia and University of Pennsylvania. Next, we have Dr. Nancy Cook, professor in the Division of Preventive Medicine at Brigham and Women's Hospital and Harvard Medical School. Last but not least, we have Dr. Joseph Rodricks, founding principal at Ramboll Environ, a technical consulting firm. We'll start off with a presentation from the committee members summarizing the report, and then we'll open it up to any questions you may have. Please note this webinar is scheduled to last 1 hour unless we run out of questions beforehand. And with that, I will turn it over to Dr. Stallings.
Good morning, everyone. And on behalf of the committee, I'd like to welcome you to our report brief. We're delighted to be with you today and share the work of the last couple of years. On this slide, you see an overview of what we plan to present, and as you heard, we will have time for questions and answers at the end of the presentation. As many of you know, the work at the National Academies is very well structured based on the statement of task. And so to sort of set up our report, I wanted to review this with you. In this particular report, excuse me, we were asked to consider for both sodium and potassium issues related to deficiency, to inadequacy and adequacy, to toxicity, and for chronic disease endpoints. And this last bullet point is important, and I think you'll find it as one of the new contributions of this report. In addition, our statement of tasks led us to incorporate some very specific and important prior work. The DRI Organizing Framework has been established and is the stepping off point for any work where you're reviewing previous DRIs. Specifically for this committee, there's a new, in 2017, Guiding Principles report that specifically set up the question of how to guide us towards considering chronic disease in our DRI process. And lastly, again, specifically for our committee, a systematic review was commissioned and executed by AHRQ, and this was a foundational data set that we used in doing this work. So as I mentioned, there is a DRI Organizing Framework that has 4 steps that we were required to work through for each of our micronutrients. The first is to select an indicator. And by this, it might be something like clinical endpoints or diagnostic terms, could also be biomarkers or surrogate markers. And you'll see as we work through the story that the surrogate marker process and qualifying surrogate markers was part of our task. In this setting, we're always charged with looking at the consideration of, is there a causal relationship between our biomarkers and the chronic disease outcome of interest in the setting? And that, again, became an important part of our work. When you look at this, the next step is there an intake-response relationship between the nutrient and the outcome or the biomarker? This again becomes a critical component of having data sufficient to set DRIs. The last two steps is once we've come up with these new numbers or new recommendations, we must go back and compare what the new recommendations are and how do they fit into the current population intakes. And then go on in step 4 to talk about what the public health implications are, and if there are special considerations, bring that to everyone's attention. The Guiding Principles report, and you can see the cover here, again, was designed specifically to bring the concept of DRIs for chronic disease prevention into our system. And in this setting, we also established a new approach that requires a grading of the evidence in a very standardized, precise method, and that for a body of evidence to qualify to contribute to these decisions, it had to have at least moderate strength. So that means evidence bases that are moderate or high strength would be able to be evaluated for both that issue of causality and the issue of intake response. If a body of evidence is considered to be of low strength through this process, then it doesn't qualify to contribute to this, to establishing a chronic disease recommendation. So in essence, our committee was charged to do an expansion of the DRI model. And I'm sure you're all familiar with what our established terms are for the EAR. And if you have high quality experimental evidence to establish an EAR, then you can go on and establish an RDA. If that's not the case, we have a long-standing process to establish an adequate intake, the AIs. And that you'll see was a major component of the work we did. So we had to come up with, review, and establish adequacy levels. The two other things that differ a bit, in our report, we were charged to start implementing changes in how we think about upper levels in the DRI system and move them to retain that concept, but yet to move it a bit more towards real toxicity endpoints. And we'll take time during our report today to expand upon that because we thought it was really important for the public to understand that modification. And then the really new concept is chronic disease risk reduction intake. And here I'm introducing the term that we'll be using throughout our report. The CDRR is a level now that will join all the rest of the alphabet soup and be a part of how we describe recommended dietary intakes. So I'll cover the adequacy process for both potassium and sodium, and then we'll move to the new topics that I explained. So for potassium for adequacy, what we were charged to do was to review the body of evidence. And as we did that, there was no biomarker was able to be established that met all the qualifying hallmarks. And so there was no sensitive biomarker to potassium intake. For example, serum potassium is very heavily controlled by physiology in healthy people, and therefore is not a sensitive biomarker of the variations in dietary intake. We also examined the balance studies in potassium, And because of different design limitations, such as they did not very rigorously define the actual intake during the balance, and they may not have collected loss data from all of the forms of losses, such as stool, urine, and sweat, we found that the balance studies had limited contributions, and so they were not able to really inform the DRI. So in conclusion, for potassium, none of the reviewed indicators offered sufficient evidence to establish the potassium EAR and thus an RDA. So our next step then was to say, what are we going to base an adequate intake? And in this setting, the median intakes for apparently healthy groups of people were appropriate for establishing the AI. And I'll share a little bit of the strength of that data with you. So going forward, potassium will have an AI. So this is really to give you more detail on what we use to establish this. So in the infants, starting with infants, as has been done in the past, the estimate of potassium intake in healthy infants was based upon the potassium content of breast milk in healthy mothers and babies. When you move to the 7 to 12-month-old age group, we still use breast milk as the primary liquid, but you have to add the complementary foods and beverages, and so that was incorporated into usual intake. We were very fortunate for children and then for adults that we have excellent, really contemporary estimates of dietary intake from potassium. In the US, we had data from the Haynes survey from 2009 to 14. And I should have mentioned earlier, but this DRI process is always a joint program for both the US and Canada. So the Haynes provided the US data, and the Canadian Community Health Survey System provided the data for Canada. And we were able to get the 2015 data for that. So we were able to take this and then stratify it by age and sex group. In the adults, we were using those same two databases, which nicely went through our age ranges. But I also wanted to call out that we were able to work with the subset of data from those where the volunteers, the participants, were normotensive, so they did not have hypertension, and they had no reported history of cardiovascular disease. So trying to capture this idea of apparently healthy people from the US and Canada. So this is the table with all of this summarized, but I will flip quickly to this table because often what we want to know is, okay, what changed? And for potassium, every value changed some, except for 0 to 6 months. So I wanted to walk you through this a little bit. You can see in the darker gold that actually there was one group, the 7 to 12 months old, where the recommendation increased, and then in yellow, all of the others decreased compared to the 2005 DRI report, and that was the existing set of recommendations for sodium and potassium. So compared to the previous values, what really changed? What led to this? So as I mentioned, almost everybody had reduced values, everybody over 1 year of age. And the reason for this is in 2005, much of the evidence that was used to establish the values were based on research studies that use potassium supplementation rather than simply potassium intake in the usual diet. So in our process, we did not use supplementation studies, but we used the intake of apparently healthy people. And also some of the things that the previous committee considered in establishing their values had components of chronic disease risk. And we were able to pull that out, and that would go into our new category of the chronic disease risk reduction. So again, no longer appropriate to inform this process. So with that, I'll close on all of the potassium story and go to sodium. So again, the process is very similar. We had to go through those steps and again, we found very easily that a biomarker such as plasma or serum sodium would not be appropriate. And even the diagnostic term of hyponatremia are not responsive to dietary intake. Once again, we turned to the balance studies and found that the balance studies, based on their design, were not sufficient quality of data to help for the purposes of defining sodium requirements. There was another element of examining sodium intake and health that had been proposed to the committee to consider. And there's been the question of, is there evidence that a very low sodium intake is harmful to health? And in that, the committee did particularly focused reviews on all of the diagnoses that you see here that had been called out in previous literature to be sure that we covered this important task well. So to expand upon that a bit, this is sometimes referred to as U-shape or J-shape curves, and the concern that there might be an adverse health outcome for taking very low amounts of sodium. So what our committee did was to really examine this set of data very carefully. And what we concluded is that there were a number of limitations in study design and report that precluded them from being able to be considered for the decisions around DRIs. And those problems included some of the sample size selection or the sample selection, inclusion, exclusion criteria with pre-existing conditions. There were issues of confounding variables and concern about reverse causality. And another concern is that many of the studies used a single spot urine to estimate the whole 24-hour urinary excretion of sodium. And when you do that, there is a risk of bias in those estimates, actually both on the low side and the high side, again, limiting the possibility for this data to contribute to the work we were doing. And lastly, there were really some heterogeneity in the outcomes, that sometimes if you did it this way, you got one result and another result when it was examined with slightly different methods and populations. So the committee dealt with this, I think, with a great deal of dedication, and you'll find the details in the report. So the conclusion for DRI for sodium, again, we were using an adequate intake. None of the indicators that we reviewed offered sufficient evidence to establish an EAR. However, unlike potassium, we could not turn to the typical sodium intake in the American diet because the sodium intake was now already above what we were beginning to establish as our first chronic disease risk reduction. And you'll see more of that or hear more about that when my colleagues speak. So what we turned to then was to looking at the evidence based on sodium intake from randomized controlled trials, and also evidence from the one balance study that we found that was designed in a way that we thought it really could contribute to the body of evidence. So these were the studies that were used to establish the sodium adequate intake. So for this, let's start to give you a little detail, start with the adult side on the right. So, and again, great bit of detail in the report. But to summarize, the sodium intakes from the DASH sodium trial and 8 other randomized controlled trials were the anchor data set for this. As I mentioned, we also found one balance study in adults where they were studying intake and losses and also the impact of heat stress. And from that, really found a balance level of 15 125 milligrams per day, and you will see how that was really very congruent with some of the other evidence. And as I mentioned, we found insufficient evidence for the adverse health events that might have been associated with low levels of intake. So we anchored it with that. So for children, as you might imagine, there are not a lot of randomized controlled trials for sodium intake in children. So our approach was one of now extrapolating the levels that we determined for adults for children 1 to 18 years of age. And to do that extrapolation, we based it upon looking at the estimated energy requirements of each age and sex group. And to estimate energy requirements, you have to decide on a physical activity level. And we use sedentary physical activity for this process. For the infants, the process was similar to potassium. We used the sodium content of breast milk for the youngest babies, and then added the sodium content of complementary foods and beverages to the 7 to 12 month. So again, this is the summary, but I will take you to this one, which shows you again what changed. And as you can see, there were some decreases based on the process we use for children 1 to 13. And then you see probably one of the interesting findings that even though we went through an entirely different process, we came up with numbers of 1,500 for the daily intake for most of the adolescent and adult age ranges, which is the number that was established in 2005 using very different methodology. I'd also like to call to your attention that we actually increased the sodium recommendation for the population over 51 years of age. And that was because as we examined the evidence and looked specifically at those age cuts, there was no evidence, and there was no evidence that older people needed less sodium. So as we did that, we basically brought them back up to the levels that are being recommended for younger adults. So compared to previous values, as you can see, we reaffirmed the values for the youngest and the age in the middle. And the last bullet point was the one that I thought was important for all of us to be aware of, related to people who were in that older age group. So this is, I'll close here. This was really to set up the adequate intake levels for both of the micronutrients. And now the next parts of the study really are with my colleague, Dr. Rodrigues, and then Dr. Cook, to spend more time on what the really newer innovations are, I think. So, Joe?
Yes. Thank you very much, Professor Stallings. This is Joe Rodrigues. Good morning, everyone. I have a few slides on the issue of, on the DRI known as the upper level, the UL. I will take you through that. The UL was introduced in the mid-90s. It's defined as the highest average daily intake of a habitually consumed nutrient that will pose no risk of toxicity in healthy individuals. In other words, it's a safe level of intake for to protect against adverse effects that might occur with excessive intake. And the UL is, to develop a UL, you need some information to suggest that at higher levels, there are adverse effects clearly identified and associated with or caused by the nutrient of concern, and some information about the doses at which they occur. If you have that kind of information, you can derive a UL. When the UL was introduced, it was defined around the term adverse health effects, which meant any kind of adverse health effects. That issue was re-examined in the guidelines report that Professor Stallings mentioned earlier, the report that appeared in 2017, which discussed the issue of the UL and said that there ought to be, or recommended that there ought to be a distinction between chronic health effects, which are certainly adverse, but chronic diseases as one kind of adverse effect, and distinguished from toxicity, more traditional forms of toxicity. There are reasons for that distinction. Chronic diseases are much more complicated phenomena in general and need a different approach. So the guidelines report suggested that we take a different approach, and we did that. So we began looking then at the question of adverse effects, what's been found for potassium and sodium, and in each case we sought two kinds of information. One, case reports. You know, you can't study toxicity in people. That's not ethical. So you have to find through indirect evidence, evidence for any kind of toxicity. And in doing our search, we, as I mentioned, we distinguished between, or sought to separate any information about chronic diseases associated with these two nutrients and toxicity. So we focused entirely on toxicity. We had two primary sources of information, case reports of poisonings, basically, with sodium or potassium. And then there's information developed in clinical trials with, for example, potassium supplementation or sodium trials. There are sometimes reports of adverse findings in those trials. So we went through those. The AHRQ report went through those in some detail in its review, and then we went beyond that with our own literature search. Our findings on after that kind of search were pretty simple. You can certainly poison yourself with supplemental potassium, but case reports are not useful for developing DRIs. They do not reflect, they're usually single instances of exposure to very high levels. There's always a lack of clarity about causation in those cases. There's other, sometimes confounding effects of other factors in the reports, and very little information on dosimetry. So they're just not, they don't reflect habitual dietary intake of anything. You can find with potassium evidence in the trials of that supplementation may sometimes increase blood potassium levels, producing a condition called hyperkalemia, but in adults with normal kidney function, healthy individuals, this doesn't occur. This is associated with people who may not have normal kidney function or may also have other chronic diseases. So it's not a concern, as far as we can tell, for anybody with normal, for healthy adults, for healthy individuals, I should say. And we could find no other consistent pattern of adverse events in the supplementation trial. So potassium is pretty safe. The body clears it quite well if you're a healthy person. So there's no evidence for adverse effects at high levels of potassium intake, and therefore either no reason to develop a UL and certainly no basis for developing a UL for potassium. And this conclusion is the same as that reached in the 2005 report. So we have no UL for potassium. In looking at the same kinds of literature, sources of information for sodium, we have basically the same information, the same kinds of information about acute doses, not useful for establishing a UL. There's some indication in two trials that sodium taken in some high concentrated form, I think it was tomato juice, for example, in two trials, a very high concentration of sodium, did result in some adverse effects, but there was no specific indicator of toxicity. And those adverse effects went away if that mode of administration of the sodium was not taken. The more interesting phenomenon of headaches reported in trials where headaches seem to be less prevalent as the dose of sodium decreased. But this effect is not well characterized. We didn't see a way to establish anything like an intake-response relationship for headaches. Maybe something worth further investigation, but with the evidence we had on the types of headaches, their duration and severity and so forth, we didn't have information that we thought would be useful for establishing a DRI. So our conclusion on this one is the same as for potassium. Insufficient evidence. There's no UL proposed for sodium in our report. No UL established, I should say. And here I come back to my original comments about the distinction between toxicity and chronic disease. This is different from, this is perhaps a point that requires a lot of emphasis, but in the earlier 2005 DRI report, there was a conclusion based that there was a UL established, but based on a chronic disease indicator, blood pressure, not on toxicity. We are now focusing for UL purposes strictly on toxicity, which we say we have no evidence for in the case of sodium. And the issue of blood pressure or other chronic disease indicators is going to be treated separately. So although there was a UL proposed in 2005, we are now unproposing it, so to speak, and we're going to now look at the other question of chronic disease indicators, including blood pressure, and my colleague, Professor Cook, is going to take you through that.
Okay, thank you. I'm going to go through our thought process on chronic disease and its relation to potassium and sodium. First of all, we used the strength of evidence rating across the whole body of evidence, considering a wide variety of chronic disease indicators. And as Dr. Strawlings said, we considered both causality and intake response. Both of these things are critical to establishing a chronic disease DRI. We're guided by the grade system, which is a systematic way of reviewing evidence, and it's comprised of the following components. One is study design. Randomized trials are given higher ratings than observational studies. Risk of bias, which assesses the validity of individual studies. And I'll note here that the AHRQ review included a risk of bias assessment for each of the studies included in its review. We did not undertake this risk of bias assessment ourselves. Another is inconsistency, or the heterogeneity or variation across studies. Indirectness, which is the extent to which the data addresses the question of interest. Imprecision and publication bias. Our primary source of evidence for these key indicators was the AHRQ systematic review, which was commissioned in preparation for our report. And the AHRQ review also considered the strength of evidence. However, we noted something in that the strength of evidence for blood pressure was downgraded. And the reason for that was due to heterogeneity or inconsistency in the study results for both potassium and sodium. Because of this, we conducted additional meta-analyses in our committee using the data that was available from the AHRQ report. We considered more information on the studies that were contained there, primarily to explore these sources of heterogeneity, to see if we could explain some of the variation across studies and what made them different, and also to examine the intake-response relationship. In order to establish a DRI level for chronic disease, we need to see an intake-response or dose-response relationship, and that's one of the key criteria for establishing a chronic disease DRI. So first, for potassium. The evidence on potassium was limited, and most of the chronic disease endpoints had a low or insufficient strength of evidence. These were mainly based on prospective cohort studies, which tended to be rated as having a moderate or high risk of bias. There was, however, moderate strength of evidence for an effect of potassium supplementation on systolic and diastolic blood pressure. Now, these could be used as surrogate biomarkers as supporting evidence to establish a chronic disease DRI. However, we found some limitations in the data. Primarily, we found a lack of dose response with potassium intake. We looked at the potassium changes within the trials, but we could not find a dose-response relationship with changes in blood pressure. In addition, for potassium, the effect appeared restricted to those with hypertension at baseline, and there was very little effect among people with normal blood pressure at baseline. And then there was additional heterogeneity of effect apart from baseline hypertension that we could not adequately explain with the data that we had available to us, which tended to be study-wide data. So in conclusion, although there's a moderate strength of evidence for a causal relationship between potassium supplementation and reduction in blood pressure, we could not establish a potassium CDRR due to heterogeneity across studies, and especially because of a lack of evidence for an intake-response relationship. There also was a lack of supporting evidence for a benefit of potassium on cardiovascular disease. So we could not establish the potassium CDRR at this time. Now turning to sodium. There is more data available for the question of sodium, and it's more robust. Again, most of this evidence was determined from the AHRQ systematic review. So first of all, there was insufficient evidence for a variety of indicators that were examined, cardiovascular mortality, etc. However, there was a moderate strength of evidence for 3 outcomes, chronic disease outcomes considered, namely all-cause mortality, cardiovascular disease incidence, and hypertension incidence. We also found a high strength of evidence for systolic and diastolic blood pressure. So the committee selected the most specific of these indicators, namely cardiovascular disease incidence, hypertension incidence, and systolic and diastolic blood pressure as being interrelated. And here is our view of the relationship between all of these indicators. First of all, there's a high strength of evidence that reducing sodium intake leads to reductions in both systolic and diastolic blood pressure. Now, these could serve as surrogate markers for both hypertension and cardiovascular disease incidence. However, we also had more direct evidence linking reduced sodium intake to reductions in hypertension and cardiovascular disease with a moderate strength of evidence. So these would establish a causal connection between sodium intake and these indicators. Now, the next question was whether we could establish an intake-response relationship. And first of all, across the whole range of sodium intake, there did appear to be an intake-response relationship. The question is, where do we have sufficient data to establish a particular level for a CDRR? And we use the grade system, synthesizing across all 4 of those indicators, cardiovascular disease, hypertension, systolic and diastolic blood pressure, to rate the intake-response relationship within ranges of sodium intake. So first of all, starting with the middle range, from 2,300 to 4,100 milligrams per day, there is a high strength of evidence across all of these indicators that sodium reduction leads to reduction in these chronic disease indicators. In the intake range of 4,100 and above, there are only trials reporting on blood pressure and 1 low risk of bias observational study that reported on cardiovascular disease. And because blood pressure is not a direct measure of chronic disease risk, we rated this as moderate strength of evidence. There were no trials available with data above 5,000 milligrams per day. However, we used our expert judgment to assume that intakes above 5,000 would also benefit from reductions in sodium intake. Finally, at the lower end, there were several studies that reported on blood pressure reduction with sodium intakes below 2,300. But across the body of evidence, there was heterogeneity that couldn't be explained, and there was lack of evidence on a more direct association with measures of chronic disease, hypertension, and cardiovascular disease. So this led to an overall low strength of evidence for values below this range. And our evidence did not include trials or low risk of bias observational studies with intakes below 1,000. I would also note that when you consider the population distribution of usual intakes, there's a very low percent that actually consume intakes less than 2,300. So in conclusion, there's moderate to high strength of evidence for both a causal relationship and an intake-response relationship between sodium and several interrelated chronic disease indicators, cardiovascular disease, hypertension, systolic and diastolic blood pressure. And evidence from these was synthesized to inform the development of the sodium CDRR. So for adults aged 19 to 70, the CDRR, this chronic disease risk reduction intake level, is the lowest level of intake for which there was sufficient strength of evidence, high or moderate, to characterize a chronic disease risk reduction. And for sodium in particular, the CDRR is the intake above which risk increases and above which intake reduction is expected to reduce chronic disease risk within an apparently healthy population. For adults aged greater than 70 years, there was more limited evidence, and there were very few studies that were restricted to adults aged 70 years and higher. Many adults in this age group were incorporated into other trials of sodium intake, however. And we saw no evidence to suggest that there should be a difference in the CDRR. So we use the same CDRR as the younger adults. Now for children, there was insufficient evidence to establish a relationship between sodium intake and chronic disease risk. However, we thought it was prudent to establish a CDRR in children. And to do this, as we did for adequate intake, we use a sedentary estimated energy requirements to extrapolate down to children from the adult levels. And here are the recommendations for the chronic disease reduction intakes. First of all, starting with adults on the bottom row, greater or equal to 19 years, we recommend reducing intake if it's above 2,300 milligrams per day. We recommend a similar level for children and adolescents aged 14 to 18. For children, the recommended intakes are lower. For children 1 to 3 years, it's above 1,200. Children 4 to 8 years, above 1,500. Children 9 to 13 years, reduce intakes if above 1,800 milligrams per day. Finally, I'd just like to compare this to the previous recommendations based on the 2005 review. Now, importantly, that considered upper limits. They did not have the chronic disease paradigm upon which to base their recommendations. However, you can see that several of their recommendations are similar. Those in yellow are highlighted are those that have changed. They're only for the children and adolescents. For the rest of them, our chronic disease risk reduction intake is actually the same as that was previously called an upper limit. This is because the upper limit in 2005 was based on randomized trials of blood pressure and sodium reduction. We use some of those same trials in our evidence review to look at the dose-response relationship. So in summary, for all ages 14 and above, the CDRR is the same as the previous upper limit, but it's now more appropriately defined as a limit at which chronic disease risk will increase. So now I'd like to turn back to Dr. Stallings to talk about risk and special considerations.
Thank you very much. So in closing our presentation, as I mentioned at the beginning, one of the final requirements of our task was to come back after we had done all the work you've heard about and to look at it as how does this fit into the risk of the population today. So in that sense, I have mentioned that we were very happy to have very contemporary dietary intake to inform our work. The NHANES for the US, the CCHS for Canada, and the FITS data set, which particularly filled in gaps for infants and toddlers and dietary intake. And as you've heard, for both sodium and potassium, we established adequate intakes. And when you think about an adequate intake, remembering that it's the median of a population, documented population intake, about half of the people are going to be above it, and about half of the people should be below that level, which is what gives you the median. So when you think about this, for the people who are above, whose intakes are above the adequate intake, we have confidence that there would be low prevalence of inadequate intake if people routinely consume that amount. However, on the other side, again, very characteristic for all the years we've had AI, we cannot be so confident of the adequacy of the intake of the people and the groups of people who are taking less than the AI. So that global overview still remains. The new and exciting value that you heard about was now comparing the sodium intake to the chronic disease risk reduction. And Dr. Cook has walked you through that with the benchmark values above which we would like the different age and sex populations to reduce their intake. So particularly to look here at potassium and now looking at the adequate intake of the different children and adults and pregnant and lactating. If you look at the values that are in the 40s and 50s, that goes along with what I mentioned, that we expect about half of the population to be above the adequate intake. What the lower numbers suggest that within our population, there certainly are some age and sex groups that are going to deserve more attention as the other agencies and groups who will be in charge of communicating this new report into the health communications part. And for example, for potassium, when we looked at all the intake across the US and Canada, it became apparent that the group with the lowest potassium intakes are the non-Hispanic Blacks across all DRI groups. Now, there are also special considerations that I will just mention in passing and encourage you, particularly those in the healthcare, the doctors and the dietitians, to go back and look at this because there are some very specific considerations that need to be called out. One of which will be situations where people are having excessive sweat loss, whether that's related to high temperature or physical activity. And there's a whole collection of medications that do have an impact on the metabolism of potassium, and if the losses are excessive. And again, you see these mentioned, and it particularly goes to the treatment of people with hypertension and with heart failure. Special considerations, again, if you go to the report, you will find a very nice review of literature and commentary on everything from rare diseases like adrenal insufficiency to much more common conditions in our healthcare setting today, like chronic kidney disease or type 2 diabetes. So now looking at framing the same summary for sodium, here on this chart you see both the numbers related to the AI and also those related to the CDRR, since potassium has now both of these values. As we've mentioned, the actual routine intake of people in the US and Canada is very high, the sodium intake, and in fact exceeds the adequate intake almost universally. So it is important for us now to start thinking about the CDRR value and how it will help both population work and clinical work. Unfortunately, here you still see that the vast majority of people are consuming dietary sodium at levels higher than the CDRR. When we examine the patient, the population dietary patterns, we noticed that the non-Hispanic white adults tend to have the higher sodium intakes. And again, I will refer you to the report for full details, but again, there are special considerations here in sodium and diet and health. And also refer you to the report for a number of, the committee took a good deal of time and effort to think about where our knowledge gaps were and to make recommendations for future research. And we'll, again, refer you to the report. We are very much appreciative of our sponsors, both in Canada and the US. And of course, without their support, we could not have done this. And I absolutely want to call to your attention the hard work and the dedication of a really spectacular committee and team from the National Academies. I have rarely seen a group of people who are prepared to come to the table and listen very open-mindedly to complex work and to work for consensus. And I really applaud the report that our team produced. Thank you.
Thank you all for that presentation, and we'll now move into the Q&A session. A reminder for viewers, you can click the Q&A button on the bottom of your screen. First question, how many micronutrients have DRI values based upon chronic disease endpoints?
Well, really, this is the first one using this new approach of chronic disease risk reduction. And I think that's an important point to make. In the past, this has been in the consideration, and as Dr. Roderick mentioned, part of what this committee was able to move forward is shifting some of those concerns from what we call the upper levels into this new category that we think will serve the DRIs and public health very well.
Thank you. Next question, is there value in using sodium serum levels to determine adequacy of sodium intake for an individual?
That's always an interesting question, and I think the answer is no. So serum sodium values in healthy people are extraordinarily well controlled by the body's metabolic systems of checks and balances. So that serum sodium within the normal or reference range really would not be a good indicator of either too much sodium or too little sodium in a healthy person. And this was Dr. Stalling, sorry.
Thank you. Next question, did the committee consider salt-sensitive individuals versus those who are not? Would that shift the CDRR in any way?
This is Dr. Cook. We did notice that there were differences in effect sizes for both potassium and for sodium among people with hypertension. And it's possible that there are individuals who are more sensitive to sodium. However, it's very difficult to characterize individuals as to their sodium sensitivity without conducting elaborate studies. We hope in the future that we'll be able to do some of this with other biomarkers, including genetics, that could help distinguish individuals who are sodium sensitive or not. One key thing is that we found that there was an effect among those, a strong effect among those with hypertension, and for sodium, an additional effect among those who were not quite hypertensive, who haven't reached the higher levels. We don't know what happens among those with below average blood pressure, and it's possible that their blood pressure and their hypertension could be affected by sodium sensitivity. So this is something that we definitely consider a future research need. We need to do more work to be able to characterize individuals who are sodium sensitive and not.
Thank you. Next question, did the committee consider potassium to sodium ratio?
This is Dr. Cook again. We did consider potassium sodium ratio. Several studies have shown that the relationship is stronger when you consider the sodium to potassium ratio. However, there was limited evidence to really establish these dietary recommended intakes based on the ratio. So this is another area where we consider that more research is needed, whether that can be used to establish dietary recommended intakes. In addition, another area is the relation of these nutrients to energy intake. There's been some suggestion that sodium levels should be adapted to energy intake requirements. Right now, there's limited data available, and we did not feel it was sufficient in order to characterize dietary recommended intakes. But that's an area of future research that should be conducted.
Thank you. What definition was used for hypertension in the review of the evidence?
This is Dr. Cook again. When we reviewed the evidence, we used the definition that was used by each particular study. And as you know, this definition has changed over time, but we didn't have the original data on which to recharacterize the populations. So in many of the studies, it was 140/90. In some of the older studies, it might even be higher. So it did vary a bit. These studies typically did not use the latest guidelines, which indicate stage 1 hypertension at much lower levels, however, but used previous definitions of hypertension.
Thank you. Next question, did the committee consider adjusting the CDRR for caloric intake instead of having one blanket recommendation?
This is Dr. Stallings. I think in part, Dr. Cook just covered that. So the committee certainly considered that, the concept of sodium intake being tied to caloric intake, which is sometimes referred to as the sodium density. And as she mentioned, after looking at all available evidence, it's insufficient at this point in time to contribute to the public health recommendations of the DRIs.
Thank you. Next question, how are the DRIs used in the broader picture of nutrition guidelines? When will they be updated next?
This is Dr. Stallings. That's a good question because the DRIs are a fundamental component of many of the food and nutrition related work of the federal government. So you'll see the DRIs referred to in programs like the WIC program, a school lunch and breakfast, from the SNAP program. All of those in their operational or their regulatory process refer back to the DRIs. And therefore, when a DRI for nutrients such as we've just done changes, it'll be up to those different agencies to think about how this anchor change in public health recommendations will be worked into changing, will be worked into considering their programs. The other big process that the DRIs are always an important contributor for the dietary guidelines for Americans, which, as you know, are reviewed every 5 years. So probably one of the first times this will get used is as the DGA committee starts to think forward. To the last part of the question, there is no scheduled time to update any specific nutrient in the DRI process. And certainly it was beyond the scope of our committee to do or think about that. But there is a process that is always ongoing, that looks at what's the public health significance and what is the change in the body of the evidence that was used for the previous DRIs. So we can't predict what the next nutrients will be, but there is a very well established process.
Thank you. Last question that we have time for today. Are all the recommendations based on population data, or is there evidence of dose-response relationships for individual patients? It seems that each individual responds differently to sodium intake. Is there evidence to restrict sodium intake for a healthy person with normal blood pressure?
There is limited data actually in those who have below average blood pressure. So those who are not hypertensive, who don't have a stage 1 hypertension, previously called pre-hypertension. So we would benefit from having studies among people with lower levels of blood pressure. I will note, though, that a substantial portion of the adult population does develop hypertension. Probably about 60% or the majority, have hypertension among U.S. adults, and it continues to increase as people age. So that a great majority of the population will have hypertension at some point in their lives, and thus would likely benefit from sodium reduction.
Thank you. It looks like that is all the time we have for questions today. Once you exit this webinar, you will be redirected to our report page at nationalacademies.org/DRI sodium potassium. Also on that page, the slides from today, as well as a recording of this webinar, will be available sometime next week. And with that, I would like to thank all of our speakers and thank you all for tuning in and participating.